You know, I know Vipap Seti since we started the Retinawesome, but I did not meet him personally yet, but I will. So I have to tell you guys that we are going to be, I'm going to send the family to the city of Barcelona, so there will be a great opportunity for us to meet. And Aishwarya, how's it going? You live in Mumbai or you live in Delhi?
Your audio is closed.
Ah, yeah, your audio is off yet.
I live in south of India. It's called Coimbatore.
Oh yeah, great to see you again, and thank you very much for participating with us. We want to start the cases right now, but I have to tell you something. What we did 1 year, 2 years ago, things are switching. You know, they're changing so fast, and I'm pretty much involved. And my video today is going to be 3D. I'm involved with the French Academy of Surgery in robotic surgery and things. And we're going to get to this point in a couple of minutes. But we have to think on what we should be doing, because things are changing very fast. And of course, today the technology is so good. The cutters are very fast. The imaging systems are very good as well. The microscopes, the OCTs, and things are getting really, really better. And the thing I want to point out, and we are going to discuss this within the presentations going on, is that should we let anybody else do the surgery for us? Should we rely on a robot? How could we control the robot's hands? I was watching the French Academy. They are doing so much these robotic surgeries. In Brazil, we are doing as well for abdominal surgery, for thoracic surgery, for all specialties. But you know, their forceps are quite large, and for you know, adapting these to our forceps, and very small forceps, 25G, 27G, even 23G, for doing these epiretinal membranes. This is tough. This is going to be tough to prepare a good robot to do very accurately and have the membrane filling on the hands. So it's not easy at all. So I would like to start the case. If you want to share, Francini, because I know you have a very good case for you know, the Retinawesome 22nd. If you would like to start, I'll be very happy to have you start this meeting. Are you ready for that by now?
Okay, I can share my screen. And Dr. Babak, nice to see you too. We are planning to go to India one day. I hope next year. Utsav.
Well, always welcome.
Yes,
Yeah,
we're gonna go
really
to
would like
India, and then we are gonna organize the Retinawesome there. And after this Retina World Congress and the Brazilian next week, Brazilian Brevs virtual retinal surgery meeting ends, and the Rajiv is coming from Canada. So then we are gonna start working hard with the meeting from in India. Okay, Vipap.
Surely, 100%.
So I'm going to present this case, but I'm going to present as a presentation just to contextualize a little bit, okay? This guy, he's a, just a second. Okay, can you see my screen? Oops. Can you see my screen?
Not right now, not yet.
Okay. Now?
Yeah, it's pretty good now.
Okay. So this is a 36 years old guy, a mechanic. So he suffered a penetrant trauma with an intraocular foreign body. And he has under 20 in his right eye and light perception in his left eye. But he has color perception. Why is it important? Because the cornea was like this. The wound was so grave, that so damaging, that the person who has seen him before, he could not suture the cornea, so he used the biological glue and a contact lens to seal the wound. So you can see here, and these are the images, the tomography, where you can see the intraocular foreign body, the metallic one. And as he has color perception, and we know that, why? When we know that we have 640 red cones, 32% of green cones, and only 2% of blue cones, and he was able to distinguish between white and blue. I thought he had an option to go under surgery. So what we did was this combination technique here that you can see. So we had to take off this cornea, and we take off the graft. So after we placed the with just a second, I'm a little bit faster than the video. Sorry. So we took off the cornea. Then we had some synechia, and we took the lens that was all fragmented off. And after we placed a keratoprosthesis, as you see, here we are placing the keratoprosthesis. And when we got into the vitreous, we saw that there was an endophthalmitis. The vitreous was very clouded. So we managed this with vitrectomy, taking off all this with opacity. So we then identified the foreign body, and we took off from the sclerotomy. We enlarge it, and then we take the metallic foreign body after this. Then we got into it again, and we finished the vitrectomy, the base, and after we did under laser 306 degrees and finished with silicone oil. Then we replaced the graft with a tectonic cornea, and we also performed antibiotics at the end of the surgery. He involved well. Here, as you can see, it's a tectonic cornea, but he was able to count fingers after that. The retina was applied, there was no chamber reaction. And the point here is when we have some light perception or color perception, maybe it's time to try to do something for these guys who are very young, and maybe not just to save the eye, but also sometimes save the vision. Now he's waiting for another corneal transplant, and we are going to see how he's going to be after that. Thank you.
Francine, amazing case. It's very difficult to to consider, and how could you take the sensitivity before the surgery, and how reliable is this test? For example, you've got the 64 sensitivity for cones and for blue, and how do you get this accurate sensitivity, and how accurate is that? Because
no, actually it's by literature, because we know that we have this kind of percentage of cones and green, red, greens, and blue cones. And blue cones are the most sensible, and they are the fewer one. So when you, I think when you have this capacity to distinguish color, is because you have cones that are operating, that are good still. So that was the point. If he has, he is able to distinguish color, maybe he has a chance to gain vision.
Yes, I got it. And how easy, because you've got this intraocular foreign body, and how easy or how difficult was it to do the keratoprosthesis in this case? What type of keratoprosthesis did you use?
The regular one, nothing very special. We had one of the first Retina Awesome. We have this friend from Mexico. You remember him?
Yes, yes, yes.
Oh, yeah. And it's the same. Jose Dalma. He had a very big, a very beautiful keratoprosthesis with a huge visualization. But this one is the keratoprosthesis that you find in the market. I'm sorry for that. Find in the market, and it's not so difficult to place the keratoprosthesis. The tip here is you see that I put ring here. Let me put a ring here. Let me share it again. Sorry.
This she was Maria Martinez Castellanos. She participated in the first and the second, actually, the Retinawesome. The first as well.
No, but the one who has the keratoprosthesis is Jose Dalma. Jose Dalma is from Mexico.
Ah,
And
okay.
He does this keratoprosthesis. He has a very good one. And as you see here, we have this ring. This ring is to stabilize the eye, because when you may do the cornea transplantation, the people who has anterior segment who has a lot of experience, sometimes they don't use it, but they have vitreous. And here, how we would take off the vitreous, we could lose the stability of the eye, even with the irrigation. But as we are going to work at the end of the surgery with open sky, we left this ring, and then we put we put the silicone oil before we remove the keratoprosthesis, because I thought if I did this with only BSS, I wouldn't be able to do it. So I prefer to place the keratoprosthesis, remove the keratoprosthesis, and then place the graft, and after that I could remove the ring.
Yeah, so you're going to be removing the ring after you put the silicone oil, makes it it's more stable actually.
Yeah, so you should put, I think when you do vitrectomy and you have to do the keratoprosthesis, you should put this ring to stabilize the eye and left the ring until the end of the surgery. And so you put the silicone oil first of everything, and then you finish the anterior segment.
Yeah, because otherwise you don't have the ring, the eye might get soft, and then silicone oil could, probably not fit in very well. So it's better to put it first. Great case, really, really awesome. And it's even greater the way you achieved very good visualization with the wide angle systems. You could see everything, and you could perform great vitrectomy, switching the outcome, and got some vision back. This is great. Congratulations, Francine.
Thank you.
And anybody wants to comment? And I know, Aishwarya, in India, you've got this good and cheap, and very good actually, because Natarajan was showing me some years ago some of his keratoprostheses. Do you use keratoprostheses, and do you have a special brand that you could probably mention us? And could we probably get it from India by buying these and you selling us your labs? Do you have anything fancy or different?
Excellent case, Francine, ma'am. Very well managed. We use temporary keratoprostheses to manage these kind of cases, and there are few cases where only these kind of keratoprostheses don't work. There we use, along with mucosal graft, something called as LVP K-Pro, which was developed along with James Stodosh and his guidance at LV Prasad Institute in Hyderabad. So we regularly do it in our institute at Coimbatore in Eye Foundation and manage these cases. And there is another way to manage these cases is by using endoscopic vitrectomy, where the visualization is very difficult. So we can use this endoscopic vitrectomy where there will be a heads-on display, and from there you can you need a certain amount of learning curve, but that can also be managed in cases where there is no visualization. And LVP-K Pro is and Orolab K Pro is available in India. I can share the details. You can get it from India also.
That's very nice. I'd like to see it.
Yeah, for sure. Thanks, Aishwarya, for your comment. And if you want to keep on going, Dr. Nayaka, and present your case is a very interesting. Thanks a lot for agreeing to participate. And I want to thank Dr. Vaibhav Sethi for introducing us through Pen Ophthalmologica. Dr. Nayaka, he's the guy. Thanks a lot. And if you want to keep going with your case, Aishwarya.
Yeah, I'd be happy to share. Vaibhav is my very close friend. So we trained together at LV Prasad. So though he is in north of India, south of India, but we've been together for last 10, 12 years. So can I share my screen?
Sure, go ahead.
Dr. Francine, which forceps were you using? That is quite an interesting forceps. What is it called? The foreign body forceps which are you using?
Actually, I confess I don't know the name, but you saw that he's flat, so it's able to fit. But I bought it from India. I bought it from Alibaba, and because we needed a stronger one, but it doesn't have a name. But I bought it from you. Sorry.
Nice, that's nice. I'll find out.
Vaibhav, is my slide visible?
Yes, it's visible.
Yeah.
Perfect.
Can I go ahead, sir?
Oh yeah? You're ready for the video?
Yeah. So I'll be talking on management of large macular holes and refractory macular holes. So large macular holes are not very common, not something which we'll not see in our daily practice. It is something which we'll always be able to come across in our daily practice, where the minimal linear diameter is more than 400 microns. So 5 to 44% of large macular holes have been reported to be remaining open after primary surgery. And Chen et al. Reviewed 251 articles where inverted flap treatment resulted in better closure rates and visual acuity when compared to standard ILM peeling for large macular holes. So by and large, we use inverted flap technique for all the holes, but when it is more than 1000 microns, we generally try to use something known as free flap to cover the macular hole. So the goal of the surgery is something which we need to ponder over, that whether it is anatomical closure or functional visual gain. So let us see with how free flap, which is described by Morrison et al., helped in my case. So this is a case of large macular hole. This 68-year-old female present to me with minimal linear diameter of 1600 microns. So this is the case where after doing the primary vitrectomy, there was an associated epiretinal membrane as well. So once we removed that, we harvested ILM free flap from nasal part of the retina, and then placed it over the macular hole. And care was taken not to stuff it into the hole, and it was stabilized by viscoelastic so that it doesn't fly off while doing fluid air exchange. And once done, after doing a fluid air exchange, post-operatively, patient had a good closure of 6/24, and by 3 months, there was complete closure and vision stabilized at 6/24. So based on this confidence, we also we got a case with where the gentleman was 57-year-old male, had decreased vision in the left eye for 5 months. This same patient had macular hole in 6 years in 2017, where we after the surgery he had a good visual outcome, improving to 6.6. Then after 1 month back, he had vitreoretinal surgery elsewhere and came back to us with vision of 660 in the left eye, 6.6 in the right eye. This was uh, post-operative after the macular hole closed, which was operated in 2017. This was this persistent macular hole after the first surgery in another hospital. So we could see the autofluorescence showing hyper-autofluorescence, which um, uh, uh, told me that there can be a good functional outcome. Though the minimal linear diameter was 812 microns and basal diameter being 800 microns, and the right eye had type 1 closure, we were a bit skeptical of which technique to be used, but there was no other option other than free flap. So the right eye had type 1 closure, so we thought we will plan with free flap, and this is the surgical video. After shaving the base, because it was already vitrectomized, we stained the ILM under here, so you could see the already peeled area. So, but there was a remnant ILM there, so we tried to elevate it through the forceps and removed all the ILM which was in the posterior pole. And at the end of the case, we harvested one free flap and placed it over the macular hole. So and then again we stabilized this ILM flap using viscoelastic, and did a fluid air exchange. This time we used C3F8. At the end of the surgery, we did an OCT. Though the from 800 microns it had reduced to 600 microns, and from 1800 it has decreased to 1400. We were a bit hopeful that it will close. At the end of 2 weeks, it did close, but still it was gas filled. So we called them after a month, and we could see the hole had not closed, though there was small reduction in the dimensions. So again, we planned for a third procedure, because primary surgery, then I had done another surgery. So we stained under here and saw that we used this technique described by Alberto, where we massaged the edges of the macular hole and harvested a graft and stabilized using a viscoelastic, and then approximated the edges. But by the time that flap flew again, so again we harvested another flap and placed it over the macular hole, and again stabilized using the finish loop. And once oil got injected, again it got displaced, but however we placed it back and closed the case. At the end of the surgery, we could see that the hole was still open. By the end of 2 months, we could see there was type 2 closure. That means there was still the macular hole, though the edges were quite approximated to the RPE. So at the end of 1 month after the oil removal, we could reach the same situation where we actually began with. Then at the end of 16 months, nothing happened, because that was the true scare. When you have a macular hole, it can lead in 1% of the cases to a retinal detachment. Nothing happened. So at this after 2 procedures, I left this case. But what I could really see in the literature was, though autologous transplant has in macular hole sizes of 700 to 800 can have good 90% closure, and even in with autologous retinal transplant you can have good closure. The meta-analysis by Frisina et al. Showed there was visually not, patient didn't improve much. So at the end of the whole fiasco, to come back to the same question, is anatomical closure is what we are trying to do or functional visual gain? Then I concluded with whatever I could understand with my experiences, mere anatomical closure with no functional visual gain should be pursued, weighing all the risk and benefits, because you are creating new holes for autologous graft. So you have to see whether it is truly beneficial. So I did free flap and it didn't improve, so I left the macular hole to be like that. And patient is doing is stable in the for the follow-up of last 2 years.
I love these techniques, Aishwarya. Very good. I use a lot. I want to ask you something. I really love to do, autologous ILM flap and covering the MAC hole. The first case that you've shown that you put the ILM over on the top of the macular hole, you said you should not go very much deep into the hole, otherwise you could probably damage RPE cells and things. And so how you just put the ILM flap over the hole and you kind of maneuver it a little bit. And another thing, while you are doing that, you get a lower infusion inside the eye, less flow. What do you do to avoid the ILM flap from escaping off the hole? You are without the sound right now.
Ashrey, we can't hear you.
I think you're, it's okay now.
Hello.
Yes, it's fine now. Yes.
Francini, before Nayaka comments, and you could comment first. But you are muted, Francini.
No, I think Dr. Hudson's question is quite clear. We all have this issue of how to keep the flap in position. So I think what Ashrey did was a very, I would say a very smart thing of placing visco and settling the flap in position. But still, even after that, you saw that the flap was still getting displaced under air. So, try your best. And I think at the end of fluid exchange, you have to just keep hold of the flap and try to bring it back to the hole and hope that it stays there. And
but
does not happen, you can have an open hole. So.
But why have you put less flow in order not the ILM flap to escape? Because if you keep flowing, and what do you do? And after the air fluid exchange, if you go straight towards the flap, of course you dislodge it. But so you go nasal to the optic disc, at the optic disc, where you should stay.
Yes, I think that's what Ashrey also did. You stay away from the flap till the very end. On the optic nerve head or nasal to the optic nerve head, do not come close to the flap like we do in ILM flaps as well, so that you don't displace that through currents. And maybe placing in PFCL also could be of help, but again, once you do PFCL air exchange, the same problem will happen. Once air comes in, then the turbulence can just make the flap fly away. Or the slight fluid interface. Yes.
This is a very good point. I love to use PFC because I use the PFC, and I have this video called hold cover technique that I put the PFC and the ILM flap is there, and so I just move it very lightly, very carefully towards the hole. It doesn't escape because the PFC actually helps to put it down. So after my air fluid exchange, I go straight towards the PFC, remove it, and then I move it. I switch, as you said, ViveHap, to far from the ILM flap and go towards the optic nerve. So things get cool. Francine, any ideas?
No, actually, I was about to say to Dr. Shrike, I apologize to Dr. Alpatov because he was the one who published it. But I've been using it. I learned from my preceptor, Dr. Marcio Nehemi, that in the beginning, when we did not have OCT and we don't know actually about removing peeling IOL, what we do for closing macular holes was just that. We messaged the retina to close the hole. So he was the first one to publish, but that's something that we have been using a lot of time. But not, of course, that is a very, very good publishing and a very good way of doing this, because sometimes when the hole is very big, as you showed and as you did, and you don't manage to close it, this is the best option to do, because we can at least restore a little bit of visual field. And patient sometimes, especially if he doesn't have the other eye, or the other eye is not so good, he can manage the head and have a better vision, and he can manage the scotoma that that persists a little. That's nice. Thank you.
So Aishwarya, do you want to close your comments on your cases?
Well, tissue can give any visual gain, like an retina from elsewhere, or amniotic graft. So would you stop at free flap, or would you do something?
I think that's the question we have to ask ourselves. I think the retinal autograft has shown in the study by Dr. Tamir Mahmood that it has a role in certain large holes. Like maybe your case, maybe if you want to give one more attempt, then retinal autograft would be the only choice that you should plan on doing. Though I don't have much experience in that, but that could be one of the options, that at least placing a nervous tissue there could regenerate and realign with the hole. Closing it, and basically the aim should not be closing the hole. That's the question that you have, and that's a very apt question. It should be actually functional visual gain. So then only you should plan for a surgery in case you are going to be sure that you're going to give the patient some vision improvement, not just closing the hole on OCT.
Recently, I did a surgery very like yours, but he has a retinal detachment, and when I have retinal detachment, and sometimes you put the perfluor to stabilize the retina and then manage the peeling, but I was not able to grab the IOM, so it's very hard. Then I took up the perfluorocarbon, and then I perform it without. The other one that I did very near of this another surgery, I couldn't reach the IOM. It was very difficult because the retina was so flattening. And then what I did when I did the fluid air exchange was just message the retina as you did, and the result was so nice. So it's sometimes we have to use everything that we have right to accomplish a better result, I think. Congratulations.
Congratulations. And I have to mention that this is interesting. I don't know whether this is coincidence or not. And I think Francine might be right with these comments. I think Dr. Marcio Nehemi does that since long. But I remember years ago when I published in Retina Today in iTube a video using the ILM technique. I did not call it stuffing technique, but actually I had this ILM rolled like small tubings and like 4 or 5, and then these tubings that I could put inside the hole. This was a technique because the ILM was kind of rolled inside itself, having some rolled edges. And so I would be putting one by one inside the hole, and I did not call it, the stuff-in technique. But interestingly, this when I launched this video in iTube, people from Retina today, they published this magazine from that year. I think it's kind of 4 or 5 years ago or more. And then they were impressed with the technique, and at the same PDF that was shown from the magazine was Maria Berrocal showing another case. And after this was published, I don't know whether this had an impact, but when I started going to events and congresses abroad, people were doing the same. They were starting doing the same technique, and they were calling this a stuffing technique. And I don't want to tell you that because I want to get the grants for that, but I'm just telling that might be a coincidence, and the people might be doing that since long or longer than me. But this publication was a kind of hallmark from this technique, because after this, in all Retina specialized congress, very important ones, I've seen people doing the same. This is very interesting to know, and I will share with you later, in another opportunity, this first video that I recorded. Very good visualization system, of not 4K yet, but still very good to watch. Thank you very much for the comments from everybody. And Olivia, do you want to present your case? You are ready for presenting your case?
I am ready, Hudson. Thank you. Let me see to share my.
I have to tell you, guys, that I have the honor to have Olivia here, that I don't know personally yet, but she's friends with Marcelo Murilo Sassamoto, and we are from, I could say I'm Brazilian, but my father was Bolivian, so we are kind of neighbors and probably relatives. I don't know.
Thank you, Hudson, for the kind invitation. It's always a pleasure for me to participate in Retinawesome. Let me see if you can see my screen.
Yes, if you want to put it full screen, it's going to be better display. Yeah, very good now.
Okay, hi everyone. It's always a pleasure to participate in Retinawesome. Today I'm going to talk about rhegmatogenous retinal detachment after an artisan phakic IOL implantation. This is a 41 years old male that did a LASIK surgery in Peru. Here we can see the myopic procedure. And after that, he continues advancing the myopic, so he did an artisan phakic lens implant. After a year of the artisan phakic lens implant, he went with a rhegmatogenous retinal detachment in the left eye. Here we can see a cataract formation also, and here we can see all the retina detached. We did a lens calculation with Barrett, and we went on an IOL explantation, phaco, intraocular lens, vitrectomy, and gas. I commence with trip and blue dye, so assured that the capsule was a dyed. Then I use viscoelastic material to protection above and behind the lens. Then I do the scleral tunnel. Remember that this rigid lens, you need 6 millimeters. to take them off. So then I disenclave the side, one side. I thought this was going to be difficult, but it's not too difficult to disenclave it. Then you rotate it to take it out from the narrow part of the lens. Remove the phakic lens. And then sutures, I place sutures to the scleral tunnel. After that, phacoemulsification was performed with a monofocal intraocular lens in the back. It was a normal phacoemulsification with the lens in the back. After that, I place sutures in all the incisions, and I decided to use hooks to have a better visualization in the posterior pole. I did a 25 gauge pars plana vitrectomy. Here we can see the myopic fundus. And also this patient went, remember, on a circumferential scleral buccal procedure 1 year after he had the artisan lens. So we can see here the indentation of the buccal and a lot of lattice lesions around the periphery. I went shaving all the base. It was easy because he had the previous circling scleral buccal. We can see a couple of lesions in the periphery, a lot of this the holes in the I decide to do a little interchange, and I decide to ferry.
You are frozen a bit, but it's going.
Because
Yeah.
I didn't find a big hole or anything. Yeah, and to that, this is like 2 or 3 weeks after the surgery. He was very worried about having good vision, but everything was going on. Thank you for the invitation.
Thank you. And Francine is asking some questions. And Francine, could you
No.
ask Olivia?
Yeah. I like the way you stabilize the lenses, and so it's very nice option when you have to manage this kind of lenses now, when you have to work with myopic patients, because sometimes even if you don't, I don't know if he had, I didn't understand, because actually your audio was freezing.
Oh.
But I don't know if the patient had another stability, any kind of stability.
Yeah, the difference is that patient has first a LASIK surgery, then the artisan phakic IOL implantation. 1 year after, and this was not with me, he had a rhegmatogenous retinal detachment that was fixed with an scleral circumferential buccal. 13 years he was stable, and then after 13 years he came with a redetached retina in the left eye. So it was and most inferiorly retinal detachment. So I decided to remove the artisan lens, do the cataract surgery, and here are a lot of important points because the cell endothelial count was important. The IOL calculation was very important because he's 41 years old and he wanted a good vision, and he had the LASIK surgery, myopic, and okay. So the vitrectomy was good, but I did gas, and he's going very good.
Oh, that's so nice. But you how did you do this calculation, this IOL calculation? Because it's very hard. And sometimes we have to think, actually, the people who deal with anterior segment has to think that they have to manage the IOL calculation before they put the artisan. So after, when you have to remove it because you have the right one, you know. It's something
Yeah,
like
this is a very important point because he had these procedures 15 years ago with another surgeon. So for calculation, I use multi-formulas. I always have the SRQ2, but with this case, the Barrett Universal was the medium between all. I use the SRQ2, the high GIS. I also have the Barrett, and I use Panacea also. There is a page that Panacea IOL calculation. So with all this, I mix it and had this very good result. -1 is very good for him.
wonderful, especially because he's myopic, he has myopia. So when people has myopia, he doesn't deal very well when he comes hypermetric, right? Yeah. Congratulations.
Thank you.
Yeah, I was reading to your comments, Francine, as well, asking Dr. Nayaka on the glio plug and the use of methyl cellulose, 2%, 4%, and he said that 2% is enough. And how you compare stability produced by the PFC as compared to methyl cellulose, Dr. Nayaka? Oh yeah, we can't hear you yet. I think you are mute. Yeah.
Am I audible? Yeah. So we actually did a study in our hospital for large macular holes where we compared gas versus air, 30-30 eyes. So what both the groups had inverted flap. The idea of doing inverted flap, even Michalewski et al. Published in 2011. The idea of inverted flap is when you heal the ILM, there will be increased retinal pliability. So once you increase the retinal pliability, that you have to capitalize so that the edges of the macula becomes reapproximated. For that, this inverted flap will give a sort of anchor these edges and give that direction to this retinal pliability to reapproximate the edges. But this cannot be extended to free flap technique because it cannot anchor it. But by some magic, we are expecting so that it anchors this macular hole. So whether we use PFCL methyl cellulose, that is only as a temporary measure to keep the flap over the macular hole. Once you remove it, again it is exposed to currents of the fluid in the retina, in the vitreous cavity, and it can fly off. No matter what we do, it will fly off, as I showed you in the second video of the second case. So it is very difficult. We can't compare because another risk of PFCL is if it seeps through the macular hole and becomes a subretinal PFCL, again you have a problem. So I would rather not use PFCL unless the retina is detached.
Oh yeah, okay, I got it. Thanks. And
Back into Dr. Olivia and Dr. Vabla. May you ask her the question?
Yes,
Sure.
Dr. Olivia, how did you disengage the artisan lens? What is the tips? Like somebody asked, because we normally also place in the retrofixated IOLs as a secondary IOL option. But what is it? Did you use a needle to disengage it? Is it easy to do it?
It is easy. The truth is that it was my first time. I read a lot of articles seeing how to disenclavate it, but it was very easy. I just use a needle, a simple needle, and my chopper, and you do like this from the back to the top, and it's very easy, soft.
You didn't cut it, you know.
No, you don't cut it. You just because it is like enclavated in the iris. So you go back and take it out. And it is very easy. I have two port size, 1 millimeter port size each side. So it's easy to move one side and to the other side. After you disenclavate both sides, you have to rotate it very carefully, because in these patients you have most of the time a lot of endothelial cell loss. This patient was 1,000 and less endothelial cells, so it's important to have a lot of viscoelastic protecting the cells, and rotate and take it out. These are rigid polymethyl methacrylate lenses, so you have to open the 6 millimeters to take it out.
Very good.
Thank you. Will you be doing a LASIK again to reduce that -1 diopter refractive error that patient has? Will you do again?
I used the calculation with Barrett Universal. That's the best formula when you have myopic treatment with LASIK. I also see all the formulas like Haigis, and use also Panacea in the page. You look Panacea IOL calculation, and you insert all the data and gives you a very good number. So I mix all this information to have my number.
Perfect.
Thanks. And Pedro Serra Cabasca is asking from São Paulo. Pedro, they have this Italian group that says that glial plugs could probably not work well for macular holes. Do you want to comment on that, Pedro? Pedro, are you there? Do you want to comment yourself, your question, and do you want to ask it live?
Now I understood. Glio is from gliosis, right? Is that
Yes,
it?
yes.
Okay. I have.
Yeah, that's the same
lost the
question.
glio term.
I think you asked in the chat as well, Francini.
Yeah, I didn't. I haven't understood the glio plug as not as a technique, but I thought it was something else. So I got a little bit lost here. Thank you. Okay, as a
Yeah,
complication.
and he's commenting this could probably happen as a complication. But my comment and my experience, and of course, I wouldn't be stuffing in the macular hole with the plugs and one after another of ILM. But I think if you get some inside the macular hole, and that is going to stick with the whole walls and approach the edges. And so this glio action and of attaching the edges and like a plug, like a glue, and that's going to help and also help close the hole and creates an anatomic shape from the hole. So I don't think you should be putting too much of ILM and stuffing it in the hole. And if you put enough, and that could well help to close. So I think it's probably the same thought you have, Francini.
No, but I have a question, because when you put a lot of tissue inside a macular hole to close it, you're going to have a reaction over there. But the point is not just closing the macular hole, it's the vision. What we're looking for is to regain vision. And I don't know if it really works, because I use IOL technique over the macular hole, but actually I use it do a very large IOL pulling, because this way you are relaxing the centrifugal force, and the hole is going to close. Obvious, if you have a very big macular hole, you won't have you have to put something inside. But I don't know. I'm not very comfortable with putting a lot of stuff inside the macular hole.
And Rodrigo Jorge has a good experience in amniotic membranes. And
Yeah, but he just cover it or you put inside it as he does with IOL inside the hole. As Dr. Mitri, our friend, the late Dr. Mitri, he used to say that you could do a little pedunculo and leave the pedunculo over there and just put it off. But instead of stuffing a lot of things inside, that's my point. I think Dr.
yes,
Nayaka,
Dr. Dmitry used that stalk so as to put not everything inside, as you said. Yeah, it's the hinged technique that we had it commented here by Dr. Yoshihiro Yonakawa. He likes this hinged technique as well, and works good. I think any technique could work very well as long as you do it carefully, avoid too much pressure, avoid too much stuff. You put in the right positioning, and you do an air fluid exchange, and keep it right there. And I think that helps a lot. And maybe some inflammation around that area, or maybe even some blood that could, small particles, small blood, a little bit could help in closing. This is something that could be considered. So many techniques can be used, but I will have to consider all these complications, possibilities, and I think we are learning to do the best. We have to do all techniques, but I don't think there is one technique very much better than the other. Unless the inverted flap technique is a very good one, and it's been helping maybe a little more. André Jucá presented some time ago this comparison between these techniques and the percentages of success rate for closing the macular holes. So I think we have
Dr.
to
Nayaka has some
consider all that. Aishwarya, do you want to comment? Your mic is closed.
Sorry. What we have to understand is all macular holes beyond a certain level of diameter cannot be closed. So we should not attempt the inevitable. So in 2006, Europe et al. Published one paper where they, by photo ablation of the ILM in rabbit eyes, they removed the ILM, which increased the pliability of the retina by 1.28 times. So every retina has when you remove the ILM, it stretches to a certain limit. So that is different for different eyes. For example, in myopic eyes, it is already stretched too much, so it won't stretch beyond a certain level. So all these other factors which are not seen in the OCT should be considered, and then if it is possible to close it, but closing is not by mere closure. We have to reapproximate and restore the photoreceptor layer. That is when you'll have a visual outcome. If you don't re-establish the photoreceptor layer and interfere with the anatomy by stuffing with any other ectopic tissue, you will have a good OCT to show to the patient, but there will be no functional visual outcome. So that is what we have to understand and prognosticate the case and do these inverted flap technique or maximum of free flap technique and leave it at that. And as Vaibhav also told, some autologous grafts have also helped to gain some vision. That can also be tried. But trying amniotic membrane graft in a retinal case has a role in preventing an RD or something like that. But for visual outcome, I feel it is not necessary.
Yeah, I agree with you. And the first case you shown, Dr. Nayaka, I like to consider the shape of the hole. The shape, sometimes even chronic holes, the shape plays a very good role on having it closed in the outcome or not. So this shape that you shown the first case, the hole like that, like almost approaching the edge from the other. The hole is down here, but you have the upper edges like falling down. This is the best shape that from my experience, I've seen that they close well. And so the oblique shape as well, when you have the full thickness macular hole, but you have it, the cut obliquely. So they close better. But I think these shapes, they make the closure easier, unless there is a large macular hole. Of course, you gotta remove everything around. You have to deal with that. You have to get away with that by putting ILM inside the hole, or even considering ILM inverted flap technique or amniotic membrane. But what are your thoughts on that? Because I know you have great experience in the shapes of different shapes in macular holes, Dr. Nayaka.
I think what you said is correct. When the edges are elevated, when they have acute elevation of 30 to 40 degrees, they do really well. And when on NFAS OCT, if you see something which is oval or something more towards the circle, those really close well. The one which I showed you in the first case, I got lucky. I was not expecting for that hole to get closed, but in those, when it is too oblong, those cases generally on NFAS OCT, you know that those cases don't have an additional component of traction, so those cases don't do really well. So on NFAS OCT, and in fact even infrared images on Heidelberg can give you an insight on the prognosis of the oval portion.
Okay, thanks. I want to congratulate and welcome Athanasios, Dr. Athanasios Nikolakopoulos from Greece.
Hi. Nice to see
there.
you again. I just made a mistake for 1 hour.
No problem at all. So the meeting is going on here, and I like using that, the time converter. So I put side by side all countries and areas, and it's actually that one that I sent you. It's the buddy thing. Then I will refresh you on that. This gives you the day, because the time changes among countries in different times. We have summertime, but it's good to have you here, because you, Dr. Lam, Natarajan, you are the masters, and it's a great honor. And recently I've seen some very good pictures from you in Greece, in Thessaloniki, and I would like to invite you to speak a little bit about your meeting this year that we are considering participating in Thessaloniki Vitreoretinal Summer School. Thanks again. Your last video that you sent us is a very good one.
Thank you very much for accepting me. And I consider that the Thessaloniki Vitreoretinal Summer School is part of Retina.Awesome also, because Retina.Awesome now has been a worldwide step for all the knowledge transfer that we need to know. And it's only for people who are interested to give learning and take learning. And Good Nataraja and Lam and me, I mean, when you say about masters, you mean about when we are the older on this stage. So when you become old, you become a master. The thing is that when you're younger, you're doing, when you're older, you're teaching. So we decided to go to the teaching knowledge of Thessaloniki in a summer school that you were there. And it's done for 1 week, beginning of July, first week of July, between 1st and 6th. So it's all a course about wet labs, how to transfer knowledge of how to inject silicone oil, how to remove lenses, how to do drop systems. And of course, it's mainly done in order experienced people and master of surgery can connect with the people that they would like to learn something despite not being vitreoretinal surgeons. I mean, a cataract surgeon to learn how to face some complications, because technology in vitreoretinal surgery has gone so far away that it's easier to do a vitrectomy than do a cataract now. So everybody gets access to vitrectomy, not like before. because of the viewing systems of the new technology. Everybody has to do that. And people would like to do so. We have glaucoma people, cataract people, refractive people, that they would like to get access on steps of VR surgery. And also it's tricks and tips. Just to give you an asset of what we're going, is that there are 40 people that they are coming as students to learn something, and the age is between 30 and 65. And there are 42 people that they are teaching. So the teachers are equal to the students. So it's the biggest gathering for 20 surgical positions that we have in Europe. And we try to keep that up with the cooperation of you and everybody else that is working there, because we need you to become our teachers, and we need to share tricks and tips. The same thing that you're doing, the only plus that we have is just a few machines in hand. And it's a nice place to be in Thessaloniki first week of July, because it's the beginning of summer. And if you don't mind having a nice weather and doing some job together, that's nice.
Yeah.
And thank you for the hospitality.
Thanks, Athanasius. And I want to publicly invite you to be part of our robotic integration systems. And here in Brazil, we want to build a bridge between Brazil, France, and Greece, and maybe other countries. But actually, because Retinawesome is involved in Thessaloniki Vitro-Retinal Summer School, and I see that you have the great structure for this teaching. You have several microscopes, you have 3D systems, you have all stuff in vitro-retinal surgical machines, Alcons, Elaris, and as you said in the last video, every lab is invited, so we have to approach people. And the work we are doing presently with the French Academy of Surgery here, together with the iBank Foundation, is that we are building our system, our models for doing the robotic surgery. And of course, if we compare worldwide, the vitrectomy with thoracic surgery, for example, there's no way to compare as of yet, because these surgeries are already being performed robotically everywhere in Brazil, in France, and also, but there, as I was mentioning at the beginning of the meeting, their forceps to do these surgeries are very large, and our ophthalmological retinal forceps are very tiny ones. But if you have a robot that could grab them and control our how we could touch and be sensitive enough to feel the epiretinal membrane or the vitreous, and we could control the forces. And I'm going to show you my video. It's actually based on that as well. And so we could develop this faster. And because the Europe is more advanced in robotic surgery, I'm talking about general medicine, and you've got almost all the stuff we need for our robotic system integration. We just need from now on a model from the eye that we could attach it to OCT, to vitrectomy machines, to 3D visualization systems, any of them. And so your school would be, for us, the integrated school in robotics for the world to learn. So thank you very much, and this is the idea that I'm inviting you to be part with us in this project.
Always happy to be part of such a great idea that you had and got us all together and to know each other. And it's like I see Vladi up there, I see a lot of faces, familiar faces, and you become just like relatives. I mean, you see them, if you do so often, connections between us. And the most important thing is that tricks and tips and evolution, to share the tricks and tips and evolution that is not written on the internet or is not written in the books. So you take something the difficulties and for example, I can share with you, because I was trying to do 10, 15 years ago stereotaxic surgery, injecting into the vein or into the vessel by stereotaxic system as they used to be. So it was a very big opening that you do now, trying to do robotics to the eye. So I'm familiar with how the difficulties of doing something like that. And another thing that I would like to share with you is that we found out in a bad way that if something is on the surface of the retina, like a drop nucleus or a drop lens or whatever, if you try to catch it yourself while it's sitting on the surface of the retina, there is always some kind of damage happening to the retina, because you cannot control the pressure you need in order to hold something that is sitting on top of the retina. And that is why I always say that before you grasp something that is on top of the retina, you have to remove it in the center of the eye and then try to remove it. Never to grab something that's sitting on the top. Please suck it out, take it in the middle, and then take it out, because you cannot control the pressure of your fingers, how much it will be against the retina. Riemann, one of our friends, used to say that retina in this condition is like a wet paper toilet. So when you push it, you don't know how much
how much force you should apply to remove it.
Yeah, yeah. You think you don't apply for, but it's even heavy liquids. If you put them on top of something that's sitting on the leg or on the retina, can produce pigment epithelial displacement, which is then, if you have pigment epithelial displacement, has a perimeter field detection of what you did. Although you don't see it, you can see it in the field of the eye. So never grab something that's sitting on the retina. Lift it up first and then do whatever you like.
You're right. You are pretty right. And that's why if we don't know what is sitting on the retina, so you should remove it. That's your advice. And if, for example, that's why I like using oftentimes, as I mentioned earlier, perfluorocarbon liquid oftentimes could help you, because you know the how the force it displays towards the retina, so that could actually help you remove the ILM, and sometimes that could control and avoid you from pinching the membrane and lifting it up very forcefully. So it's a counter hand. Sometimes if you know what you're putting on the retina, that could actually help you. So of course, very carefully and extra careful. And robotics, and of course, cannot feel. And actually, if you are far controlling the devices, you probably lose some of the sensitivity. But of course, we are going to try to develop it more, and to have the very soft controls. And in this way, we could do better surgeries. Of course, maybe that's not for now, but for the future. Dr. Athanasios, do you have your case handy? Rajiv is telling me he's almost coming.
Let's ask Rajiv to carry on, and I'll get ready because I just entered that discussion, so I didn't have time to prepare it. So if you leave me some time, ask Rajiv to carry on.
Okay, okay. I will so before Rajiv comes. Rajiv is almost there. He's got this conflict, so he's in another event, but he's almost done, as I see here, his message. And so before we call him and we discuss a little more, I will present you my case. Let me see here just a second. And Emmanuel from Greece is coming in. It's an honor to have Emmanuel as well. Emmanuel participated with us in some Retinawesomes before, and we are friends with Dr. Lem and Athanasius and Emmanuel did a retina fellowship as me in Toronto, Canada. And we actually met in the San Francisco in the American Society of Retina Specialists. I think it was 2016. Hi, Emmanuel. Good morning. Good afternoon for you. So, maybe Athanasius,
Yes.
Doctor, our friend from your city, Dr. Esquivas, is going to join us. He's on surgery. He usually operates on Saturdays, and I have his case handy here in case he wants to join us as well. So I will share the screen to present you my video. Can you see my video?
Yes.
So I have to tell you, I've been doing more and more 3D surgeries, and so we usually do 4 or 5 cases in an afternoon. So after all these cases, and we are not tired at all by looking at the big screen, like resting like that, by doing surgery like we were playing some games. So it's much better when we compare doing surgeries, looking straight at the microscope, which is still very good, but you know, I'm loving to do 3D since 1 year the iBank Foundation has Ingenuity Alcon available, so I've been doing a lot. That's why I'm presenting you this video on 3D of a diabetic retinopathy. So this case, severe proliferative diabetic retinopathy with a tractional retinal detachment. So the patient is a pseudophakic. We open up for 23 gauge parsplana vitrectomy. You see how amazing is the image system, 3D, and we've got this Luxor microscope. You've got this plenty of fibrovascular tissue over the retina, pre-retinal hemorrhages, lots of laser. Actually, this patient waited too long for surgery, and he was referred to me because you see these tough epiretinal, pre-retinal membranes on the way. So the first thing was to remove the epiretinal tissue, as you see here, by doing the vitrectomy, a core and peripheral vitrectomy. And I'm looking after more hyaloid attachments. And when I was talking about the systems, you see here I'm using the cutter. The cutter, I did not take the see, I'm doing the lamination with the cutter. I did not take the forceps. The forceps was handy on my hand, but I did not want to use it because I could have done it better with the cutter like that, separating the cutter at the membrane attachments and delaminating it from the retina. As you see here, the epiretinal tissue is being separated and trimmed. In this way, I could have used by now the forceps, but I thought it was not necessary. In this case, if you have the appropriate force on the membrane, so my advice here is to go horizontally rather than pulling everything upwards, so it detaches beautifully, as you see here. And then you trim the tissues, the membranes. This patient had this double component of a tractional retinal detachment with regmatogenous retinal detachment as well, more peripherally in the medial periphery. You've got some haziness from the media right now because of some leaking vessels. So it's a very proliferative case. As you see here, the way the cutter is built, you can walk flush to the retina without touching it. You've got 7,500 cuts or 10,000 cuts per minute in this case, and using the 23 gauge parsplana vitrectomy with no harm to the retina, no danger to pull everything up and cause even more traction. But you see very small leaking vessels, they keep going towards the vitreous cavity. So I like using the endocautery, as you see here, with care, using the endocautery. And by using that, you should of course avoid the main vessels, and you go straight where the blood is leaking, where the new vessel is. So in this way, using now the black flush cannula, I remove. You see this hole over there is the regmatogenous component of the retinal tractional detachment. And so now things are much better. You don't have any more leaking vessels. So the wide angle, I love to use now the macular lens. It is almost a wide angle one. You see almost everything in an augmented image. So it's it easier to remove everything. Now I'm using perfluorocarbon liquid, as I said, Dr. Athanasius. Using the PFC right now, you protect the macula. That looks pretty good. Everything is flat, and you create a media for doing a good laser. You see the regmatogenous component of the macular, not the macula, of the peripheral hole. You see at the inferior arcade over there, a little far from the inferior arcade, you see that hole sitting right there under the perfluorocarbon. So it's easier, it makes it easier to do the endolaser. Right now, I'm doing the endolaser, circulating all this area. And so things that you have to weigh on whether you should be doing or not. Should we just do the laser and everything is all flat, so we do an air fluid exchange and leave the patient, the eye with air, gas, or oil? So how would you consider that? In this case, the patient is no light perception in the other eye. So this eye was only hand movements. But now it's going to get much better because we removed all these epiretinal tissue over there. So for the sake of avoiding another retinal detachment, another vessel leaking, so in this case I decided to use after all this photocoagulation to do silicone oil. And we are planning to do this protocol from some patients, comparing patients with vitrectomy, pseudophakic, and silicone oil. Vitrectomy, phakic, silicone oil. Vitrectomy for gas as well. In these cases, the protocol is for diabetic retinopathy and tractional retinal detachments that should undergo vitrectomy. As you see here, by the end of the case, removing now the silicone oil, removing the perfluorocarbon liquid, and as you see here, the silicone oil is coming in, and removing the perfluorocarbon liquid. Of course, I could probably have used the gas, intraocular gas, but because this case is what we call unique or only eye, only functional eye, I decided to leave the patient with silicone oil, and that changed a lot his outcome. He's now counting fingers easy with silicone oil. It's a 1,000 centistokes silicone oil. And the thing is that with time, silicone oil could cause complications. So, but for 3 months, it usually works very well. So everything is attached, it's stable, no leaking vessels, no hemorrhages. And so I just remove it. And the case is a lot better in terms of outcome. And now you see the retina bright, the patient is happier than having the possibility of letting the macula detaches. So that's why in this case I used silicone oil. Thanks a lot. And I would like to comment from Ashrayo. How often you use silicone oil as compared to gas in diabetic retinopathy patients?
Very nice case, Dr. Hudson. So in India, we have a lot of diabetic patients. So our primary aim is in all these tractional RD cases is to remove the traction and try not to create any iatrogenic breaks and close it under air. That gives a lot of visual outcome. So we have Barockel et al. Has actually published in 2020 or 2021, where these extramacular membranes are peeled off and the rest of the things are not pursued, so that when we it was a hard case where you wanted to remove all the membranes. When you actually when you go and chase those membranes, there will be some breaks for which you will have to give tamponade like what you have given. So in that paper, what she has told is do a minimal dissection and relieve the macula of all the traction. And once you do that, you don't need tamponade. And once you don't need tamponade, the visual recovery will be much better. So that is by and large what we try to do, try to get rid of all the traction and use no tamponade in cases where there are no breaks. Of course, when there are breaks, we use silicone oil and promptly remove after 3 months. Because these cases, if the traction is not removed and the tamponade is put, then the vitreous will remodel under the oil and cause secondary retinal detachments, which is very difficult to manage.
Yeah, thanks for the comment, Athanasius.
I have a sensitivity on silicone oil because I used silicone oil for the first time in 1982 with John Scott in Cambridge. So there are hundreds of cases of retina detachments that I have to do and hundreds of cases of diabetic traction. And I have found out that specific ways that you need the silicone oil. First of all, one-eye patients, if you put gas, the patient is not going to be able to see for 40 days. And the psychological impact of that is great. The patient with silicone oil is very happy because he wakes up the other day and he can move himself about. The second thing, you buy time. If you have done some hole that you don't see, if you have done some hemorrhage you don't see, it takes, with putting silicone oil, you have the eye for a second chance to do something. With gas, you can have a retinal detachment, you can have a complication that you cannot control. So you buy time with silicone oil. And the third thing is that hypotony is one of the worst enemies when you transfer an eye from fluid to gas, because you might lose some gas, the hole, we never suture now and everything. That's why in diabetics I used to suture. And hypotony produces hemorrhages. And hemorrhages after vitrectomy are not so unusual in real life. So you don't want to have somebody that he cannot see. So with you control the pressure much better with silicone oil. The thing that I'm trying to do with people, one eye, that they don't like to have hypotony and everything, I'm using 5,700 centistokes of silicone oil, because with this silicone oil I found out in many cases that I can leave it for longer period of times. With 1,000, they emulsify much easier. To my mind, it's a clinical observation. Don't take it for granted, but 5,700 seems to me, purified silicone, seems to me it can last for years without producing any emulsification. And these people, the only thing they want from you is to be able to move about by themselves. So I think these are my indications for silicone oil. And in cases like that with multiple traction and everything, you're never certain that you remove all the tractions. You're never certain that you didn't make any help. You're never certain that you don't have hypotony. So there are many indications. For one eye patient, my indication is whatever I'm doing, I'm putting silicone oil for one eye patients.
Yeah, that was the case I just presented. The patient was almost one eye because the other eye, actually the other eye was no light perception. So he's very happy presently. And if things get very stable, I would just go ahead and remove the silicone oil. So these paperwork.
You can see from the first day.
Yeah.
The pleasure that you have when you open up their eye and you can see it from the first day is like giving back their life. I mean, psychologically, to have gas inside and not be able to see for another 30, 40 days is not the best thing that you said, I did a good work, I fixed your eye, but you cannot understand that because you cannot see anymore.
Yes, you're right, completely right. And of course, even a proliferative berry retinopathy case without complications, without attractional retinal detachment, a simple one, oftentimes, for the sake of avoiding also hypotony, as you said, for the, to letting time for the ciliary body to build the pressure. And for a phakic patient, for example, oftentimes I leave it with air because air just lasts maybe a week or so. And so the media is clear within a week and the patient still get happy without cataract. And of course, I don't use anything if it's a simple vitrectomy in a phakic patients for just a vitreous hemorrhage coming from a new vessel over there, new vessel that is leaking, and so things after you do much laser, they get a lot better. And yeah, as you said, for retinal detachments, it is a different issue because for retinal detachment, you might get these PVR and other problems and other types of traction and shortening of retina. And so silicone oil should be considered better. And I'm talking about that, and it's very interesting that we discuss that because I know that some people are not friendly with silicone oil and some retinal surgeons prefer, but for me, it depends on the case because we get so many different cases and different options to do, and we keep trying one and other, and we know that some work better than the others. And that's why I ask Francini, which is here in our country, in Brazil. Francini does a lot of surgery as well. We talked about diabetic retinopathy this last Thursday into her course, and our presenter showed, this tabletop shape of a retinal detachment, a tractional one. So what use more, Francini, if we compare these cases with, because I think almost the same way as Athanasius, but would you do anything different?
Well, I have experience in tabletop, actually, working at Hospital das Clínicas of USP University. We have a lot of very challenging cases, and I used to work on them. And what I do is what you did, and just as Professor Athanasiou said, that I always, in the challenging case, I use silicone oil because I think we have more, the retina more stable, and you give the patient to see at least a little bit. Yeah, because sometimes these challenging cases, we change them from light perception or to hand movements or actually to some small regain vision, as I said, because I usually do very tough cases. And I like to do, I don't know if it's what you're asking me, what I think we have to isolate all the distractions and manage them as much as we can. When you have to be very careful because sometimes the retina is very ischemic and you can make some iatrogenic holes, and no, it's like this. You have to be very careful, and you have to have the expertise to do this, because when you face this kind of surgery, you have to be experimented in it. I don't know if you understand me.
Yes.
From the beginnings, if you have anybody here who is still working on vitrectomy, because sometimes you cannot be, maybe you don't have the skills to finish this case. If you have time, I can share some of them here if you want.
Yes, we understand completely. And comparing the use of silicone oil, and now by the end of the surgery, I remember comments from Ahmed Salam from USA, Little Rock, that presented with us recently, and he always comments that these cases with silicone oil, when you perform this direct exchange, you gotta be very careful when doing the exchange with high pressure. So I usually switch. If I'm doing 25G, I usually like to open up a little bit of the sclerotomy to use the back flush cannula and to remove it via 23 gauge back flush cannula if I do the direct exchange. Not if I'm using the silicone oil after the full exchange. It's not direct exchange, and then I will just pour silicone oil over the retina. But in case you are doing the direct exchange, to avoid central retinal artery occlusions and vascular problems and a very high intraocular pressure, I like using the back flush cannula. So in this case, we remove the perfluorocarbon liquid without putting the retina at risk. So these are my thoughts. And Aishwarya, you have any thoughts on that?
Was a little bit of a problem. Can you repeat the question?
No, if you do the direct exchange, you like using the back flush cannula, 23 gauge or 25 gauge, in order to avoid very high intraocular pressure inside the eye. So
I generally don't use a direct exchange because when we in a small gauge vitrectomy, the problem is while aspirating the PFCL, when you are directly exchanging, you will cause inadvertent increase in the pressure. So already, because all these diabetic eyes have already low perfusion, they can tend to snuff out. So that's why I usually do PFCL air exchange and then air and oil exchange. Okay. It's safer, actually. But for, avoiding some retinal slippage, sometimes I like to do it direct. But if you go over the hole, very peripheral hole, and avoid BSS from coming inside and making some, a roll on detaching the retina, so it's better that you follow these rules that we usually know to avoid the slippage of the retina and the recurrent retinal detachment. I think you are right. We could use both ways, direct or indirect. Olivia, what do you use? Just to add, I would put a chandelier and actually alternate between extrusion and injection under the direct visualization to avoid any excessive injection and using active section. This is what I do. When in some cases I have to do extensive retinectomy and use PFCL oil exchange directly, then due to most of us are using 25 gauge and 27 gauge, it becomes very difficult. So I remove the infusion, put a chandelier there, and in one hand I use active extrusion, in the other hand I use oil injection, and under visualization directly suck it out and keep injecting the oil, so that you don't you also do a direct injection without causing any slippage, and as well as no transient high increase in pressure.
Okay, thanks. So,
I agree with you, but there are tricks and tips on that session also. First of all, don't use anything else except perfluoctane if you do direct exchange, because perfluoctane has a different surface tension and you can see what you're doing. The second thing is always bimanual. It's always with a chandelier light. The third thing, please don't switch off the infusion line. The infusion line saves you the eye when you have a 20 millimeters infusion line with fluid or whatever you have, because it keeps the balance inside the eye in case something is happening. You don't need to hypotonize the eye immediately. So by using a bimanual method, that means that in constellation that I have, you have the dual foot pedal. The dual foot pedal, what is it doing? With the first step until the middle, you inject, and you inject silicone oil. With the second hand, you have the flute cannula in the perfluorocarbon. And when you press the pedal till the end, then you have simultaneously injection of silicone oil and removal of PFCL, and you can control it. But please, don't switch off the infusion line. The infusion line can keep you from some cases that you diffuse more or diffuse less, or you remove more. So it keeps the eye in a position that it doesn't bleed. It stays like that. So this control, and you can see when you do this exchange, you can see the vessels, if they and you can check the pressure with the vessels. So this is the step-by-step thing that I'm doing, and I never had the problem of hypertony, and that means more pressure inside the eye, because I remove and inject something. And remember the dual foot pedal thing that Constellation have. Half of it goes in, everything goes inside. So if you hypertonize it, you just lift your foot, and that's it. And you remove more than you inject. It's control. Nothing is just like doing like that. It's control all the time, visual control all the time.
Yeah.
This
is the best comment, and also visually controlled, and also with the dual pedal, of course. And I want to welcome our last speaker and keynote speaker we have the honor to have you here, Rajiv. You are coming to Brazil next week, but you are already here. So I have to tell you, me, Francini, and Seti, Dr. Seti is Indian, but he's Brazilian as well. And Olivia, and everybody here. And we want to give you a very welcome for you here, and to Brazil next week. I'm going to meet you personally. So we are so happy that we are your first approach to Brazil from this week to the next week. And I call this the pre-Brevs meeting. And Francini, welcome Rajiv, please.
Welcome, Rajiv. Hope you meet at SBRV next week.
Yes, thank you very much.
Welcome.
Thank you so much. Just 1 second here. Okay.
And so, Rajiv, I have plenty of good stuff to deliver you personally in Campinas, São Paulo.
Excellent. I'm looking forward to that. So let me just start here. Can you see my slides now, or?
Yeah, it's pretty good.
Okay, very good. So, and everyone can hear me?
Perfect.
Okay, excellent. Yeah. Well, thank you, Hudson. I really appreciate being with all of you here today on Saturday. Today I'm going to talk about my favorite topic, which is retinal detachment repair. And I'm just going to give you a brief overview of some of the key principles that I wanted to discuss today, and then show you a case at the end. So these are my financial disclosures. We as retinal surgeons deal with retinal detachment, and we see simple cases such as this one, or more complex cases such as this. And we have very good ways to fix these detachments, and most of them work, and we can get the retina on. I think we're all confident that we can get the retina on. So why change retinal detachment repair? Why should it be looked at differently, and why should we rethink what we're doing? And I want you to hear, in the words of one of my patients, how she describes her vision 14 years after she had a vitrectomy for a retinal detachment repair. You had this vitrectomy 14 years ago, and your vision, visual acuity is actually quite good. Like when you were reading the chart, you could see 20/25.
Yes.
But how do you describe, like if you look at someone's face or if you look at objects, how does it compare between in the left eye versus the right eye?
It seems very much smaller than what I can see with my right eye.
Okay, so if you look at my head, how do you describe what you're seeing with one eye and then the other?
The best way I can explain it is that it seems like the head is 3/4 the size of what I see with my right eye.
You had this. So, clearly we are good at restoring the retina into a position. We're able to recover visual acuity, but all patients don't necessarily agree that the outcomes are as successful as we think they are. Patients complain of distortion and anisoconia, metamorphopsia, and reduced vision in some cases. And so there's still room for us to improve. And a substantial proportion of these patients, like this patient 14 years later, have long-term deficits. So how can we move from, to a place where we can get better outcomes? And so I want to go over 5 important principles that I'm going to discuss today that may not be intuitive right from the beginning. So first of all, this is a patient who had a pneumatic, and you can see this picture was taken exactly 30 seconds after the gas bubble injection. So look at how the detachment has changed and how the fluid was all shifted immediately from the gas bubble. And what that should teach us is that the buoyant force of the bubble is massive. Inside the retina, the bubble can change the configuration of the retina. It applies substantial force to the retina, relatively speaking. And why is this principle important? Because the amount of force applied by the retina is related to the size of the bubble. So the amount of force in a vitrectomy applied by a full gas fill is 30 times the force applied by that small bubble. And you saw what that bubble did. Now imagine what a 98% gas fill is going to do to the thin elastic retina, and how it will displace fluid and stretch the retina. And this is the number one principle, that gas exerts tremendous buoyant force to the retina, and that this is harmful to some extent. So let's talk about the second concept. As we were trying to determine how to eliminate retinal displacement and to eliminate the action of this gas bubble, our first thought was, well, let's avoid air fluid exchange and avoid the gas tamponade altogether. Maybe that will minimize displacement. So what we did is we very slowly injected perfluorocarbon liquid into the eye. We attached the retina and lasered it, and we left the perfluorocarbon liquid in for a week, and then we took it out. If our theory was correct, that the gas was the root cause of the displacement, we should maybe not see displacement. But what we saw was the worst displacement we ever had. And here you can see that the vessels have been shifted inferiorly and temporally in the direction of fluid flow. So we call this a low integrity attachment. Now, what was happening? The superior brake was actually attached because the patient had a pneumatic, but there were holes inferiorly and fluid was shifting there, and the retina stretched in the direction of the fluid flow, and then it was held in that stretched position because the perfluorocarbon liquid was left in the eye. Now, I'm going to give you another example where we looked at buccal versus vitrectomy with scleral buccal, and we looked at the displacement rates. And as expected in the vitrectomy group, it was higher. But what was interesting was that some of the buccals also had displacement. What we found was that if you don't drain fluid, you don't get displacement with a scleral buccal. But when you drain fluid, again, you're forcing fluid to move in a certain direction, and then the retina gets stuck in that stretched position when the drainage stops. So what is the lesson here is that iatrogenic movement of subretinal fluid, no matter how you do it, and then fixing the retina in that stretched position is what leads to retinal displacement. So we should try to avoid these things. And this is why it makes sense that the risk of retinal displacement is significantly less when you use a smaller gas tamponade versus a larger one, like vitrectomy versus pneumatic. And we've shown this with multiple prospective studies. However, many people will say, well, I do fundus autofluorescence and I'm not seeing the displacement. And it is a very nuanced exam with fundus autofluorescence, and it can, the sensitivity of FAF is only 46%. So how did we determine this? We looked at another technique called OCT homography, where we took patients who had an OCT prior to the retinal detachment and afterwards, and even when the FAF is negative and we overlay these OCTs, we can see that the retina has shifted, even if it's not detectable on the fundus autofluorescence. And so the third principle is that retinal displacement is not always visible on FAF. Even if you don't see it, in 100% of the vitrectomy cases that we had, where we had this pre and post OCT, there was displacement in all cases. The next thing I want to discuss is outer retinal folds. We looked at the risk of outer retinal folds when we look at pneumatic versus vitrectomy, and we demonstrated that the visual acuity recovery is significantly less when you have outer retinal folds. Even in the vitrectomy group alone, if you get outer retinal folds, this is an issue. Now, using pneumatic as a model, we were able to study exactly how microscopically the retina attaches by doing sequential repeat OCT imaging. So here's an example where you can see this corrugation nasally forms an outer retinal fold. The corrugation develops, and then that gradually goes away over time. Now look at this patient where we allowed a slow recovery of the retina. Look at how the corrugations smoothen out over time, over 36 hours, and attach in a more natural manner. These outer retinal folds are very obvious when you use en-face OCT and can be less obvious with when you look at cross-sectional OCT. So what is the fourth principle? Rapid forced retinal reattachment is harmful. Slow natural reattachment is best. And this is because when you forcefully attach the retina, the corrugations in the retina do not have time to resolve, and you attach the retina in a corrugated manner and expect that everything will be okay. So when we do a rapid air fluid exchange and force the retina down, then put a large gas bubble in the eye, you have to think microstructurally that we are causing harm to the retina. The next principle that I want to discuss is the morphology of retinal detachments. And you know, there's this traditional thinking that you can wait 1 week for a fovea off detachment. These are 3 patients who had a fovea off detachment, and you can clearly see that there's differing structural abnormalities on the OCT. And clearly the amount of time that you allow for the retina to remain detached affects the morphology and structure of the retina. I don't believe that you can wait 1 week with a retinal detachment and expect that your outcomes will be similar. In fact, most of the evidence suggests within 3 days, and I would suggest that depending on the morphology and presenting stage, some should be done even sooner. If you look also, we recently described this other phenomenon called bacillary layer detachment in retinal detachment, and this is the source of macular hole. It's essentially a degenerative change that occurs and explains the pathophysiology of macular hole and retinal detachment and is related to the duration of disease. If you have this bacillary layer detachment here in number 2 and it progresses to stage 3, you will eventually develop a lamellar hole and then a full thickness macular hole. So principle 5 is don't believe that waiting 1 week for all fovea off detachments is reasonable. So what can we do to improve retinal detachment repair based on these 5 principles that we have demonstrated essentially with prospective data? Number 1, avoid large gas. Do not cause iatrogenic movement of fluid. Avoid rapid reattachment. And surgery should be done quickly. In the past, we only focused on single operation success rate. If I do a vitrectomy, it's 92%. If I do a buccal, it's 88%. If I do pneumatic retinopexy, it's 80% or 75%. That is one way to look at retinal detachment, but it doesn't take into account all of the things that I've discussed today in terms of how the patient sees and how the structure of the retina is once the retina has been attached. So what can we do to improve retinal detachment repair? Well, the first thing we tried was this minimal gas vitrectomy approach, where we did a vitrectomy in some cases where perhaps I didn't want to do a pneumatic for whatever reason. And if there was a single superior break, I would avoid the air fluid exchange, avoid the large gas bubble, and just inject a small bubble and allow that to tamponade the break. Now, this is one solution. It's not the perfect solution because breaks can exist in multiple locations. There can be other problems with it. So I want to share this video. I don't know if you guys have watched the show Stranger Things. It's a TV show, and we just made this little video to kind of demonstrate the various techniques that we have at our disposal. Rapid force attachment. Putting a large gas bubble in the eye will cause substantial structural change to the retina. Yes, we can put the retina attached, but it's in the wrong position. Traditional scleral buckle is a great technique, but we know that it's a little bit invasive. And pneumatic retinopexy is great, but it's not very convenient. At times, patients have to position in these awkward positions, and it can be challenging. So it's a procedure that, although works in principle, is an excellent option. It is not the solution. It's not our only solution. So I'd like to discuss today a new procedure that we've been working on called in-office suprachoroidal viscopexy for retinal detachment repair. Essentially, how the technique works is we take a guarded needle in the office with indirect ophthalmoscopy. We inject a viscoelastic material in the suprachoroidal space by indenting with this needle, observing where the needle tip is, and then injecting the viscoelastic there under the break. This leads to a temporary choroidal buckle and therefore allows the retina to be repaired immediately without forcing fluid to move in a specific direction, without a large gas tamponade. It takes into account all of those 5 principles that we discussed. You laser the break, usually on day 1 or 2, and the patient can resume normal activity immediately after the procedure. They can go to work, they can fly, they can drive, they can do everything that they normally do with no restrictions. This is a 50-year-old phakic male with 2 weeks of vision loss. You can see a stage 3B retinal detachment with corrugations. This is immediately post the sphexy, or what we call sphexy, suprachoroidal viscopexy. This is on day 1. The retina is attached. There was no outer retinal folds. Laser was applied on day 1. The patient resumed work immediately after the viscopexy the next day and came in at the end of the day, had laser. And here you see at week 3, there was no retinal displacement because we did not use any gas tamponade. And here you can see good reaction at 6 weeks. Over the last century, we've had tremendous giants in our field who have taught us how to put the retina back on. But we understand now that retinal reattachment alone is not success, that we have to strive beyond that. And Machamer said the retina wants to heal itself, and it probably will if you don't do too much to it. I think we have to step back. We know that we have all these amazing vitrectomy machines with high cut rates and excellent instrumentation, but we've ignored the effect of all of these things on the
your
thin,
sound got a little
elastic,
lower.
sensitive retinal tissue. We don't want to have an attached retina that looks like this. This is not our goal. So I'd like to thank you for your attention today. And thank you again for the invite, Hudson. And I'll see you in Brazil on Wednesday or Thursday.
Thank you. Thank you very much, Dr. Rajiv. That was the greatest explanation from our retinal detachment case and this new technique. And of course, we got to be very careful about those exchanges, those fast exchanges, those, the vessels displacements. And you showed this very, very well. Thanks a lot. But the last minute of your presentation, could you just, so that we could close and have comments, and the sound was a little dimmed. Could you just explain a little more the last minute of your explanation?
Yeah, sure. I mean, I think that what I wanted to say, do you mean the suprachoroidal viscopexy part or
Yes,
the last
yes.
part?
From that part on, yeah.
Okay. You want me to show the slides again, or do you want me to just
Just
discuss?
discuss. Yeah, the slides were good.
Yeah, I mean, I think that what I was trying to show was that when you look at the principles that we talked about, that we are convinced 100% that, using a large gas tamponade has some harm. It helps, but it has some harm. Forcing the retina to attach helps to get the retina attached, but it does some harm. Waiting to do surgery next week when you see a patient today has some harm. And so when you take all of these different things into account, we've thought about it, and pneumatic retinopexy is our first line treatment here in our practice in Toronto. And now we've introduced another office-based technique that also has the same principles, where we're minimizing the effect of gas, we're minimizing the effect of rapid drainage, we're allowing the retina to be repaired immediately in the office, and in addition has the advantages of potentially allowing the patient to resume normal activity immediately. And when you put all of this together, this is what we feel is going to be a new addition to our armamentarium for retinal detachment. Not every case, of course, but will allow certain cases to be repaired in a very elegant manner with very little invasiveness and morbidity for the patient. So I think that we've demonstrated that if you can achieve a bleb creation with a viscoelastic underneath the retinal break, that the retinal detachment can resorb and reattach, and that you can laser the tear, and that you can avoid all of these potentially harmful actions that we're doing. And I just summarized at the end by saying that, this focus for the last century was on getting the attachment rate high, and I think that was a very valid thing to do at that time. But we've now evolved and we've learned more, and now we have to realize that just going in and doing a surgery and saying that the retina is attached is not the final objective. It's not our ultimate goal. And so we have to push the envelope forward, and that's that's why we are advocating for a different approach. And it doesn't really matter if you do pneumatics or buckles or vitrectomy or the suprachoroidal viscopexy, but to keep these 5 principles in mind when you're deciding, should I use PFCL? Should I drain this fluid? Should I do subretinal fluid drainage with a scleral buckle? Should I do a pneumatic with a huge gas bubble or a smaller one? It applies to every single type of procedure.
Thanks a lot. And just wanted to close this session thanking you again for these great sessions, our retinal fellows. All here, everybody. loved your presentation. As you see here, the class is,
Thank you.
is full.
Thank you. Thank you so much.
Thanks a lot. Everybody's learning. And could you please, Francine, close this session for us, and thanking Rajiv once again?
May I just half a minute?
Please.
May I? First of all, to congratulate on Rajiv for an excellent presentation. I think I'm learning all the time. That's why I'm following you all the time. I'm learning every day. And this was a new learning. The only thing that I want to point out that is a very specific technique for very specific cases. It's just to replace some sort of pneumatic retinopathy, but not in multiple tears. You don't do that in multiple tears cases. Do you do it? That's one question. And there are the other issue that you put it, close the hole and not draining the fluid. I mean, draining the fluid is not the objective of everybody who's doing vitrectomy or doing surgery. Closing the hole is the objective. If you close the hole, the fluid is going to go away. So the huge bubbles and the huge displacement and the huge perfluorocarbon pool exchange doesn't help you to save the problem. The problem is if you close the hole. But this is what we always say. That's why when we use gas, we used to say that you don't need to drain the whole fluid. If you just want to avoid the folding of the retina, not only the displacement, but the folding also of the retina is done with forceful gas injection. And
Exactly.
the fluid moves and folds. So the thing that you taught us and the thing that we knew is that you don't inject
Recording
forcefully
in progress.
and you have to close the hole, not to drain the whole eye. And of course, it doesn't work whatever you do when you have epiretinal membranes. When you have epiretinal membranes, it's another story. And the faster you do it, the better. But my presentation, that is not enough time to show it, was showing that even very, very late detachments can be surgery after 6 months or 1 year, and then you have results, visual results. How retina is so fragile and so strong in cases like that. And thank you for congratulate you because you show a whole visual thing of a very experienced surgeon. But I think you're young. How old are you?
45.
45. You're young for a retina surgeon in my time. So you're a very experienced all-around projection of what you're doing. I congratulate you. We would love to have you in TVRS to teach people how to do it correctly.
I thank you. And I'm not claiming to have the right answers, but I think that what I've learned is that I don't accept easily what anyone tells me. I want to understand and I want to, prove it to myself and then do the research that's necessary to demonstrate and to learn. So I think that, age is definitely a factor, and I think that over time, you change your approach. But I think that these principles that I've learned through evidence, through prospective data, through imaging, that wasn't present. Like, people like Linkoff and Kriesig, and these people didn't have the benefit of autofluorescence, ultra wide field, swept source OCT, wide field imaging. They assumed that non-drainage was better, and they were right, but they couldn't prove it, and so I think that we are in a different era now where we have this technology and we're able to use it. And I feel like everyone kind of forgot about retinal detachment. We all were doing anti-VEGF injections and all the research was in that area. We had these amazing vitrectomy machines that could fix the retina. But from a research perspective, none of the companies are very interested in that. It's kind of was thought of as, an area that was kind of done. We knew how to do it. And so I think by revisiting all of these things with the imaging that we have has taught us a lot. I just want to answer your two questions. The first one, we do pneumatics on a very wide range of cases, from giant retinal tears to multiple breaks. They don't always work, and it's usually our first approach for many cases. When it doesn't work, we believe that surgery quickly does not harm the patient. In fact, when you can get the retina attached without having surgery, we believe that they're better off. And when it doesn't work and you go to vitrectomy 2 or 3 or 4 days later, that you haven't lost anything, and usually you've gained because their fovea is attached within, probably 18 to 30 hours after the detachment. If you do face down positioning, it's even faster, like 2 to 4 hours. So when the pneumatic fails, there's an inferior break or there's some break that you can't address, and then you go in and do your simple vitrectomy or buckle at that time. In regards to your comment regarding how to do a vitrectomy, we played around a lot. So we tried, 60% gas fill or 50% gas fill or 80% gas fill or 40% gas fill. And regardless of that, if you leave a lot of fluid and you put a bubble in the eye, a large bubble that's big enough, there's two things that are happening. The bubble is pushing the fluid away, and then it's being held in that stretched position because the bubble doesn't let the fluid go back. And so if you don't drain, you just close the break with a vitrectomy, but put a decent sized bubble. I would say anything more than 40% gas fill, or even let's say 50% gas fill, you will still get this retinal displacement. So how can you avoid or minimize with a vitrectomy? Let's say you have a 12 o'clock break. You can do your vitrectomy, don't drain, and then inject a small expansile bubble that will, because it's the initial bubble size that's the problem. It's not the final gas bubble size. And so using a small expansile bubble could be used. And so this is a concept we call minimal gas vitrectomy. We do it if there's, for example, if there's a VH and I don't know where the break is and I find a single 12 o'clock break, I didn't do a pneumatic because I couldn't see, and then I put this small bubble in and allow it to expand. Or if they have a superior inferior break, we'll do like a segmental buckle inferiorly and then a small bubble. This is if we're trying to minimize. But as we all as a community understand these principles, I'm certain we're going to find better ways of doing it. And there's so many things coming out. There's tissue sealants for retinal detachment where you can avoid air and gas, like with vitrectomy. There's newer approaches to scleral buckle, like what I showed today, with the viscopexy. So I think that as a community, we're going to solve these problems, but we have to open our eyes first and accept that there's a problem. I think that right now there's a lot of denial that my outcomes are great, and I think we know that it can get better, even though they are good, it can be better.
From my experience, you're doing a great job. From my experience, that it's not since 1980. So please ask Nakamura to send you my email.
Sure.
Email to send you an invitation to come to Greece.
And thanks everybody.
1 week, people.
Thanks, Athanasios. Before we close, just Rajiv, one very special person wants to say goodbye, hello to you, is Dr. Lam. Dr. Lam, my professor. Dr. Lam, where are you, Dr. Lam? I saw you coming in. Dr. Lam is our master.
And Dr. Lam.
Hello. It's always wonderful to hear what Rajiv had to share with his experience with pneumatic. I think he's now the guru, the king of pneumatic these days, and so.
Well, I'd like to. So we have Wai Ching was obviously I did my fellowship with him. My first 4 months of retinal surgery were with him, and Emmanuel is here also, who was my co-fellow. So it's nice to see everyone, and I still remember, Wai Ching, the other surgeons would be doing like 7 cases, but Wai Ching would have 4 cases, but he would be so slow and methodical and thinking about every single step that he did. And I learned that he was always thinking about what he was doing, and that's the biggest thing that I learned from Wai Ching. So I greatly appreciate, all the training that you gave me and showed me that how you think about things.
Thanks a lot, everybody. Thanks, Dr. Lam. Good to see you, and I hope to see you soon.
Yes.
Thanks, Dr. Hussein, for joining us as well. It was great, and thanks everybody. And we close the session. It's going to be available soon in a YouTube channel, and we're going to share with you. Thanks a lot. Have a great Saturday.
School of Surgery. Do a Toronto School of Surgery.
Yeah, that's.
Make a Toronto School of Surgery. Just another session of Retina.Awesome.
Bye-bye.
Appreciate it. Have a good weekend, everyone. Take care.
Thanks.
Have a good weekend.
Thank you all. Have a guys Saturday.